18% risk reduction for falls. If you're giving 700 to 1,000 units, significant risk reduction and fairly consistent across these trials. These same trials are now displayed as a meta-regression. On the left, we're looking at the dose administered and the risk reduction observed. Each dot represents a different trial, and you'll see a significant inverse association. On the right, we look at the 25-hydroxy-D levels in relation to risk reduction in the 6 of these 8 trials in which 25-hydroxy-D had been reported. And here we see a same inverse association. It appears to me that you need to be down, reach a level of 16 nanomoles per liter or higher in order to experience the benefit of vitamin D in fall risk reduction. We had not, until about 3 weeks ago, any data on doses of D higher than 1,000 units for falls. But we do now have a trial that was just published in acute hip fracture patients who were treated with either 800 or 2,000 units. We knew that 800 units was effective. We wanted to know whether going higher to 2,000 units a day would be more effective in preventing falls. In this same trial, we also examined another intervention, which was an unsupervised, very mild home exercise program. The people, after their hip fracture, stayed in the hospital for 5 days. Each day they'd get a training on how they were to do the home-based exercise. And so we wanted to see if that would lower risk of falls over that 1-year period following the hip fracture. The study subjects consisted of 173 fracture patients. Most were women. The average age was 84. 77% of these people had had their fractures at home or at least not in an institution. The results with regard to falls are that increasing to 2,000 as compared with receiving 800 had no further effect on fall risk reduction. There were the same numbers of falls at 2,000 and 800 units. The extended exercise program, compared with no home-based exercise program, significantly reduced the risk of falling by 25%. When we looked at the subset of people who had actually complied with the exercises by doing them at least once a week over that 1-year period, they had a 36% risk reduction in a fall in that 12-month period after. So it looks as if this approach is useful. Next. We had as a secondary endpoint in this trial hospital readmissions. How many people had to go back to the hospital at some point in that 12-month interval? And it turned out that here, the higher dose D resulted in a 39% reduction in risk of having to go back to the hospital for any reason. Now, the biggest reductions were in admissions for fall-related injuries, 60%, and very interestingly, there was a 90% risk reduction for being admitted because of an infection compared with in 2,000 versus the 800-unit group. The extended exercise program did not affect significantly the readmission rate. Next. So it appears from this trial that the people who in the placebo group, well, not placebo, getting 800, were above that threshold of 60 nanomoles a liter, and it doesn't really surprise us that they had no fewer falls. We're disappointed, but I can understand that. It seems that the vitamin D and the extended home exercise programs have complementary or additive benefits in the care of these acute hip fracture patients. And with the D providing a huge reduction in readmissions and exercise providing a significant reduction in falls. Next. Let's turn now to the complicated area, but interesting and important area of the effect of calcium and vitamin D on fracture rates. We will look at several, have highlighted in orange the several meta-analyses that we will look at. There's been an array of these meta-analyses. It's kind of hard to get a handle on exactly what the story is. Next. When we look at the summary of calcium alone trials, this is calcium with no added vitamin D, we see no real effect that is significant on hip fracture risk of the calcium supplements. No significant effect of calcium alone. Next. On non-vertebral fractures, this would be all non-vertebral fracture risk, there is a trend toward a modest risk reduction. It does not quite reach statistical significance. Chang did a meta-analysis and looked at the calcium alone trials shown in the panel here, risk reduction, so that you had about a 33% lower risk of developing diabetes if you had adequate intake of calcium and D compared with inadequate intake. We had done a 3-year randomized controlled trial looking at calcium plus D versus placebo. To evaluate this diabetes question a little bit, we went back into our archive and measured the fasting blood sugar at the beginning and at the end of this 3-year trial. And we examined the changes in fasting blood sugar over 3 years according to the level of glucose that you had at the beginning. It turned out if you had perfectly normal fasting blood sugar at entry, both the placebo and the calcium and vitamin D groups progressed to, had the similar increases in fasting sugar over that 3-year period, just what you'd expect. Very interestingly, among those who had impaired glucose tolerance at entry into the trial, that would be defined as a pre-diabetic, blood sugar between 100 and 120 milligrams per deciliter. The placebo members of that group had the expected more rapid conversion to full-fledged abnormal fasting sugars. The calcium and D group did not progress to full-fledged diabetes over that 3-year period. So it looks as if the calcium and D may retard the progression from diabetes to full-blown diabetes. This needs to be examined in other trials, and it is being. We have a prospective trial underway with this